If nothing, is very complex. And the better off we all can become in terms of learning of the intricacies of it, the better off we can understand how it will impact our lives and the lives of our community. And for that, we are grateful to have somebody here to help explain that to us. And without any further ado, I introduce to you Dr. Bill Hathaway.
Thank you very much. I appreciate that kind introduction and the opportunity to be here. Can everyone hear me in the audience? Is there problems in the back? I guess if I'm talking and you can't hear me, you can't raise your hand. So that's a self-evident question there. Okay. While this warms up, I want to extend a sincere thanks to Mary Ellen for sponsoring and taking care of my dad. I don't know what my brother and sister and I would do without her. It's a pleasure to come back here. I had a great time when I gave the talk a year ago. There's a lot to cover, and my first talk, as you may or may not remember, was the Affordable Care Act for Dummies from a Dummy. And now we have a new talk. We call it a Progress Report 2014, The Good, the Bad, and the Ugly. And I want to start out with a few parenthetical comments. First and foremost, as much as possible, I hope this is an interactive conversation. It's a little bit bigger group than sometimes that's easy to do. We'll try to have some time for questions and answers at the end. Secondly, it's a very highly emotional topic. All you have to do is pick up the newspaper or turn on CNN or turn on Fox News or turn on NPR. And it's an exceptionally emotionally laden, politically charged topic for a whole host of different reasons. And my goal in tonight's talk is not to come down on one side or the other of whether this is good, bad, or ugly, but to inform what's good, what's bad, and what's ugly about the Affordable Care Act and sort of give a perspective of where we are 1 year into the passage of this legislation. And I want to emphasize that, we all bring inherent biases into this conversation, whether we're young or old, whether we have a job or we don't have a job, whether we have health insurance or we don't have health insurance, whether we're Republican or Democrat, whether we're hospital administrators or patients. We all have a perspective that makes us look at this legislation differently than other people do. And so when you hear my perception or my take on this talk, you have to understand where I'm coming from. I'm a registered independent. Probably sends chills down my father's spine to hear that. I'm a hospital administrator and a physician, meaning my primary goal is to make sure my patients are cared for. I live in Western North Carolina, which is the South. The South is different than the North in terms of the coverage for people and the amount of health care that people have. I see patients every day who come into our emergency room and don't have access to the care that they need to have and don't get the quality of health care that I think everybody deserves. I believe health care is a fundamental right for people. It's as much a right that we should provide people as, bread and butter and shelter. Okay, that's my beliefs. I'm just putting that out there. I don't want to have a debate about whether I'm right or wrong, because that's not the purpose of tonight's talk. But when you hear me talk about this, you'll have to understand that some of the things I say are in the context that I believe it's important that we try to provide as much health care as we can for everybody. Because what's wrong with health care right now? Well, we spend more and we get less in the United States. There's numerous statistics that show this. Our costs are increasing, and even though we spend more, our longevity, our neonatal death rates are higher, our longevity is lower than other Western countries. Our access to care is poor. We have increasing burden on the individual for their own health care, and many people getting catastrophic illnesses who end up destitute and impoverished because of unexpected illness. There's lots of waste in health care. Doctors ordering tests that aren't necessary, or putting patients through tests and procedures that aren't valuable, and that in general, and you're all patients, we're all patients, I'm a patient, you know, I think satisfaction with the healthcare system is poor. And it was out of this background and this context that the Affordable Care Act came and said, how are we going to address these kinds of issues in the United States? And so keep that in mind, that when we talk about the Affordable Care Act, it's in the context of, you know, this is where we're going with healthcare, but don't forget where we've been. It's not like we're leaving a place that's also rosy and fantastic and wonderful right now. So we're going to start out, I don't know if you remember this, but we did this last time. We had a few test questions that I wanted to ask just to see where everyone was. In the past, the questions read, will the Healthcare Reform Act, now they read, does the Healthcare Reform law require nearly all Americans to have health insurance starting in 2014 or else pay a fine? No, yes, or we don't know. Get your answers, and the answer is, it's going backwards, so how do we get it to go forward?
Yes.
And the answer is, of course, yes, the law does this. Everyone has to get health care insurance or have a fine. That's part of what the individual mandate was all about. We're going to go through 10 questions here. Once we get through the 10 questions, I'll talk a little bit about the Affordable Care Act so we're all on the same page about what it really is. And then at the end of the talk, the last half, we'll talk about an update and a progress report on where we're going. Question number 2. Does the health reform law establish a government panel to make decisions about end-of-life care for people on Medicare?
No.
Yes, no. No death panels, really? Are you sure there aren't death panels? Fox News says there's death panels. All right, no, the law does not do this. So right, it doesn't do that, but it did establish something called an independent payment and advisory board, which is designed to help control the cost of Medicare. And we'll talk about that. Okay, number 3, does the health reform law give states the option of expanding their existing Medicaid program to cover more low-income uninsured adults? Does it give them the option? Of course it does. And what did the great state of North Carolina choose to do and the great state of Wisconsin choose to do? Not to exercise that option. So they didn't expand Medicaid, and we'll talk about that and what the implications of that decision are for hospitals and people. And only 27 states in the District of Columbia chose to expand Medicaid. Okay, so the answer, as we talked about, oh, it's going backwards here, sorry for this. Got a touchy mouse. Okay, does the health reform law allow undocumented immigrants to receive financial help from the government to buy health insurance?
No.
No, this is an educated audience. Who wants to give the talk? You guys seem to have all the answers, so that's good. That's excellent. No, of course it doesn't. Well, maybe not. Of course it doesn't, because that was popularized that it would give benefits to undocumented people, and it has no intention of doing that. So no, the law does not do that. Now, the question of whether we should care for undocumented immigrants and give health care to people who are suffering on our streets and in front of our very eyes is another question, but I'll stay away from that one right now. Does the health reform law increase the Medicare payroll tax on earnings for upper-income Americans? Are more affluent people going to be taxed more to help pay for this bill? No. No? Yes? No?
No.
Oh, okay. Well, sorry, folks. It's exactly what it does. It taxes the upper-income earners, and I'll show you a little bit about that later if we can get to it. The incomes of above $500,000 a year annually and $1 million a year have a proportional increase in their taxes. So they tax the affluent to pay for this, in part. Does the health reform law require employers with 50 or more employees to pay a fine if they don't offer health insurance? Yes. Sure does. And that was one of the ways they had to pay for it. They had to get all the employers to offer their employees health insurance. So the law does do this. Does the health reform law cut benefits for people in the traditional Medicare program?
No.
Yes? No?
Yes.
No? Mostly no? It's a smattering? So it's kind of a trick question because the health reform law doesn't cut benefits for individuals in Medicare program, but it cuts Medicare payments to hospitals over the course of the next few years. So you all, no offense intended, but there's a little bit of gray hair in the audience, you all will be receiving your Medicare benefits as designed. We will just get paid, me being in my hospital hat, will be paid less to provide those benefits. And that's a problem, and we'll talk about that in a little bit here. So the law does not do that. Does the health reform law provide financial help to low and moderate income Americans who don't get insurance through their jobs to purchase coverage? Yes. Of course, subsidies. That's one of the biggest proponents now. There's an issue with that. We'll talk about that. Supreme Court is going to address that issue later on. You probably heard that, and we'll address what that circumstance is. Does the health reform law create a new government-run insurance plan? New government insurance plan to run alongside the plans offered on the exchange? No new government insurance plan. Nope. And then question 10, does the health reform law create health insurance exchanges or marketplaces where small businesses and people who don't get coverage through their employers can shop for insurance and compare prices and benefits? Yeah. Of course it does. We've heard about that. Healthcare.gov, right? Disaster a year ago, re-enrollment period this Saturday, and we'll talk about how that's gone and whether that's been good. So that'll be the progress report that we talk about. Okay. So the Patient Protection and Affordable Care Act, that's the official name. The unofficial name is Obamacare. As they try to build the airplane while they're flying it, put the wings on while they're flying it, someone's trying to chop it off, and it's been a battle. It'll be a battle. It'll continue to be a battle. It was signed, put into act, the legislation was signed in March of 2010, and what was interesting, if you all remember or don't remember, I remember vividly, it was not a bipartisan act by any stretch of the imagination. The House vote was 219 Democrats were for it, 34 were against it, and not a single Republican was for the passage of it. And the Senate was the same. 58 Democrats, 2 independents voted yes, and 39 Republicans voted against, and 1 did not vote for it. So you know, just by nature of how the bill was passed in the legislature, that it's going to be controversial, and just by nature of the fact that we've become a country where our politics has deviated from one of conversation between the 2 political parties and gone to one of the extremes. We can't define anything except by the extremes, that it's going to be a battle for the next few years, and it has been a battle ever since it was signed. Okay, Patient Protection and Affordable Care Act. Key objectives of the act. Number 1, expand coverage among the currently uninsured. So they wanted to expand coverage. We'll look into it a little bit later as to whether that's happening. Number 2, decrease the rate of growth of spending in healthcare. The rate of growth of spending was untenable. We can't afford how fast costs have been rising, and if the costs continue to rise at the rates they've been rising over time, the country will go bankrupt just trying to pay for healthcare. Even if we taxed everyone to beat the band and cut all the other benefits, we still couldn't afford this rate of rise. We have to do something to cut the rate of growth of spending. And that doesn't mean decrease the quality of care or the care you get. It means get better care for a better dollar. Provide financial incentives or penalties based on quality performance. That's how we're going to decrease the rate of growth. And then align physician and hospital incentives around care management. Instead of treating crises of care, instead of treating you when you come to the hospital, let's get people into wellness programs. Let's get people into prevention programs as a part of a strategy to manage our population health. And that's what the Affordable Care Act, at least in theory, is supposed to do. Objective A, make coverage more secure. Objective B, improve healthcare quality and safety. C, emphasize primary and preventive care. D, reduce the growth. E, ensure access to quality, culturally competent, and care for vulnerable populations. And F, promote the adoption and meaningful use of health information technology. So, laudable objectives. I don't think many of us would argue that they're things we all believe in. I would hope we all believe in those things. The question is, does the act itself accomplish that? And is it feasible that we can actually afford to do it the way they want us to do it? Well, public opinion has never been favorable on the act. That's for sure. This is taken from the Kaiser Family Foundation. If you want some, what I consider to be fairly objective information on healthcare in general, but especially on the Affordable Care Act, go to the Kaiser Family Foundation website, kff.org, and you can see over time, this is April of 2010, the dark blue line is those who are favorably impressed with the Affordable Care Act. The orange, I guess I'm colorblind, forgive me if it's red, are unfavorable, and then the gray is those who are uncertain or don't know. 47% are in favor, or unfavorable towards the act, 35% for, and 19% unknown as of September. So, for better or worse, most people are not favorably impressed by the act. What are the clinical care impacts of this act? Well, and this is a busy slide, and I don't want you to worry about all the details, but listen to mostly what I'm saying and focus on the left-hand side. The system is designed to create systematic improvements in how we deliver care across the continuum of care. That's the goal, and that's done by aligning or payment incentives to get physicians and healthcare systems to change. As an example, support primary care, prevention, and wellness, and it does this through a variety of different mechanisms, including paying primary care physicians more and covering wellness benefits and preventive services for people who have health insurance. That's critical, and that's what one of the acts is supposed to do. Payment reforms to encourage and support improved system performance. We're now getting paid in different mechanisms. Hospitals, instead of being paid for how many things they do to you, they're being paid on a program called value-based purchasing, which measures our outcomes. If we have high readmission rates for our patients, I don't get paid for a readmission. If you get an infection while you're in the hospital, before, that didn't hurt me. I get paid to treat the infection too. Now I get penalized for having the infection, and I don't get a payment to treat you for that. So we're changing the way we pay to encourage better outcomes for people. The creation of accountable care organizations, which are designed to put quality metrics as the goal for how they treat patients, control health spending, and a variety of other on down the line, including the adoption of health information technology, electronic health records, to leverage technology so that your doctors know what happened to you when you were in another doctor's office, what happened to you when you're in the hospital. They have all that information to avoid duplication of testing and a variety of other services. So those are built in. There are incentives, payment incentives built into the act to get us to change how we do that. I think perhaps the single most controversial or least favorable part of the Affordable Care Act that had people worked up and upset was the individual mandate. And of course, the individual mandate was that part of the act that said everybody must have health insurance or you're going to be fined and have to pay taxes. And the penalty for this was $95 for this current year if you didn't carry insurance for an individual. It'll be up to $325 for 2015, $695 for 2016, and then if it's a household issue, it's 1% of your income, whichever is more, is the two of these. And that was the part of the act that went to the Supreme Court for assessment, and it was proven to be okay, and it still is very, very controversial because there's a large group of people who just feel the federal government shouldn't tell me what I should or should not have to buy. But in order for this act to work, in order for us to pay for this, we have to get everybody to have health insurance, including the healthy people. That's the fundamental kicker in the whole deal. If we don't have everyone who has health insurance, we won't be able to pay for everyone who gets sick. If only the people who are sick get health insurance, we can't afford to take care of them. So this was critical to make the Affordable Care Act work. And 66% of Americans are not in favor of it. Interestingly, only 6% would be required to purchase or face a penalty, and 2 of the 3 of the 6% would be eligible to receive subsidies. So even though it doesn't affect that many people, most people, at least the majority of Americans, were unfavorably disposed towards that part of the act. Questions, concerns, thoughts about that so far? Take a slight breath.
How many people are in the Affordable Care Act? How many people have insurance through the...
So that's a good question. We'll address that later on. There's a question of how many people have been enrolled, how many people enrolled in new Medicaid programs, and versus how many were expected to be enrolled. The quick answer is about 7 or 8 million enrolled, with 8 million being enrolled through new Medicaid expansions. And then they're making projections, we'll talk about it in a minute, that are actually down. It was supposed to be 13 million in 2015, fiscal year 2015. They downgraded those expectations to about 9 million. I don't know if that's a political ploy so that if they get more, they can say, look how successful we are. But it was supposed to be up to 25 million. Remember, there were 30 to 40 million, I think, or higher uninsured Americans. And so we were trying to get 25 million insured by 2015.
We have 400 million population. How come if there's only 8 million in the program, how come it gets somebody so upset?
Yeah, that's a good question. That's a good question. You in the corner there.
Could you expand on the recent Gruber stupidity comments that have aired so widely on internet?
So I don't know if you're familiar with who Mr. Gruber is or what he said, but Mr. Gruber was a MIT economics professor who served as a consultant for the Obama administration when the act was being drawn up. And he was very influential in the implementation of the Massachusetts program, which served as sort of the model. The Massachusetts program, just so everyone knows, was a Mitt Romney program. Okay, so let's not forget that. He said, basically, he called, I mean, what you're led to believe is that he called the American public stupid. What he said was that they capitalized on the fact that the American public doesn't understand the complexities of the act. They're just too stupid to understand it all, to really understand it all, I think is a paraphrase of the way he said it. And if they called this individual mandate a tax, no one would have voted for it. If they said, we're going to have all the healthy people get taxed to pay for the sick people, the American public would have rejected this right off the bat. But if they said, we'll have everyone be required to pay for insurance, that doesn't sound so bad, doesn't sound like a tax, and so it was sort of lack of transparency and subterfuge that he said was part of the reason that the act was able to be passed. He wasn't saying they were stupid to have voted for it. He said that they used a relative lack of information on the part of the American public to make it more palatable to them, but he felt much in favor that the act should be passed. Does that make sense? All right. Okay, Medicaid expansion. So the purpose of Medicaid expansion was to get more people in the program. Again, the major tenet was we want more people to be insured because people who are uninsured have poor quality life, more financial risk, and do worse off in general. This is really, from a hospital point of view, this is very frustrating because the Medicaid expansion said that the states will get 100% of the federal funding. Remember, now Medicare, so you understand, and probably don't understand this, Medicaid funding comes from the states, goes to the federal government, and then comes back to the states, okay? We all pay in to our federal taxes to the Medicaid program that then part of the money is state allocated and part of it comes back from the state, from the federal government. And there's a provision in there that if you know, for every dollar that the hospitals pay, they get $2 back. And so the failure to expand Medicaid or the decision not to expand Medicaid on the part of many states was that they didn't want to be stuck with this 10%, be on the hook 10% later on for this expanded cost. But what it doesn't take into account of is the fact that you're paying the money anyway. It's just going to Illinois, Minnesota, and these other states next door who decided to expand it. So there's an argument about, a legitimate argument about whether we should be on the hook for this 10% later on and what that's going to do to us and whether we can afford this. But in the short run, and we'll talk about this a little bit later, I have more slides on it, it's a financial, I think, a poor financial decision in the short run. The Supreme Court ruled that it was, what they said was if you don't expand Medicaid, then you don't get any Medicare funding at all, or Medicaid funding at all. And the Supreme Court ruled that that was coercive and unconstitutional. And so they could keep their pre-existing Medicaid funding without expanding. And that's why most of the Republican-led states chose not to do it. And this is just a map that shows, you know, Wisconsin is surrounded by a number of states in the liberal part of the country, traditionally liberal part of the country. Here I am in the deep south, and we chose not to expand it in Texas and a variety of other places. Now, some of the Republican states are considering options. Indiana is one of them. Arkansas has done a waiver program to expand Medicaid, and so we may see some issues. The purpose of it was to reduce the number of uninsured, increase access to care, limit the out-of-pocket burdens on the individuals. And then there was a question about if we expand all this insurance, will there be enough providers to meet the need? Well, so far we've met the need, but I think that's a legitimate question because there is a physician and provider shortage. I know probably many of you call up your doctor and say, hey, I need to be seen, and it takes longer than you want to be seen. So what's going to happen if we bring a whole lot more insured people into it? And then, of course, if they fail to expand, there's a large gap of people who don't get it. So what about the employer mandate? We had the individual mandate that said that all individuals had to pay a fine or get insurance, or pay a fine. And then they had the employer mandate, and of course, they delayed that. It was supposed to go into effect last year for small businesses and then large businesses. It's been delayed for a year, as you'll see here. And we don't know whether that will have an impact on. One of the things we're hoping to see, the argument against the employer mandate was that people would fire people to get under the 50 employee level so they didn't have to provide benefits for their employees. So some argued that it would result in a loss in jobs, or that they would cut people's work hours so that they didn't fill the entire work time, so that they didn't have to provide benefits. And we haven't seen if that's happened yet. Employers with greater than 50 full-time employees must offer coverage or pay a fine. Employers with greater than 200 must automatically enroll unless the employees opt out. And these two provisions were delayed to 2016 and 2015. So we'll see what happens next year with that. Okay, the exchanges. I like this one. And I assume you're all internet savvy. This is a pretty sophisticated audience. This is ridiculous. I've been in healthcare.gov for 2 hours and I've accomplished nothing. Still 1 hour less than she spent watching cat videos. So that being said, you know, I think it was an unmitigated disaster. None of us would argue that the health insurance market. Who's gone to the website? Has anybody gone to the website? We got one person, 2, 3 scattered people. So I went yesterday. It was fast. I found out that there's no fewer than, I think 80 plans came up when I typed in my demographics, and 54981 is my zip code, and it was really, I mean, it worked pretty well. I don't know if the plans are worth anything. They look pretty expensive to me, but at least the website was working much better. Now note her face here. If you remember last year, she did become a little bit distressed over time because it was a disaster. And unfortunately, or fortunately, and I would say unfortunately, this became sort of the, you know, Obamacare's not working because the website's not working. Well, this isn't Obamacare. This is just how you get to the Affordable Care Act and get the health insurance plans on the exchange. But it became, you know, such a public disaster that it really was too bad. And at least we hope it'll be better. So on the exchange, individuals without other coverage and small employers can purchase their coverage. It's hopeful, Paul, you asked this question, an estimated 27 million people will enroll in coverage. That's the hope. Through 2017, we enrolled, we'll see again some other slides later, about 7 to 8 million the first year. And that there'll be subsidies based on what your income level is. And as you saw, almost all the people who get insurance through there are qualified for subsidies. Yes?
You know, when I went on, when we bought insurance, they don't take into consideration how much money are you making? Can you afford this or not? And they'll just tell you this is how much it's going to cost you. Well, by going on this website, they took into consideration how much income, and so I could get the very same coverage that I'm getting right now, but for way, like half the cost.
Right. On the website, what you can do, and get a little bit ahead of myself, but what you can do that you couldn't do before is shop for plans. Before you had to enroll and see what happened. Now you can actually shop for plans, and we'll talk a little bit about that now, but it tells you what your expected payment will be, what your deductible will be, what your premium will be, and it's very, you can compare gold, silver, platinum plans one to another. It's very, I think it holds a lot of promise. I don't know if it's going to work, but it's much better than it was. In addition to the exchanges, there are changes in the Affordable Care Act that apply to private insurance. I think most of these are pretty good. You can no longer be excluded from a plan based on pre-existing conditions. Amen to that. How many people lost their insurance and then could no longer get coverage? Require health plans to, and this is very important. One of the reasons health care costs so much in the United States is that the insurance companies take all the dollar, okay? 20, 25, 30%. Who's got the profits? It's not Mission Health System. Our margin was 1.7% last year. 1.7% profit margin. I don't know if any of you do business. You know, we have net revenues of $1.4 billion. We're a pretty big system. And we had A 1.7% margin. Okay, that's nothing. You know what Blue Cross Blue Shield has? I don't even want to think about it. Lots more than that. Yeah, so don't go there. So the goal of this is to say that the insurance companies can only take 15% of the premium dollar towards their cost instead of 20 or 25%. They can only take 15%. If premiums increases are subject to review, there'll be adoption of financial and administrative standards to promote. I mean, I'm a physician. I can't even read my EOB, my explanation of benefits. I don't know if I'm supposed to pay something or not when that stuff comes in the mail. And I deal in healthcare all the time. I can't imagine what it's like for everyone else. We cover dependent children up to 26, which is good. My oldest is 23, my youngest is 18. We eliminate lifetime benefits, so there's no longer a cap, which is good. You know, if you're really sick and you spend all that money, the last thing they need to do is say you spent too much, you're done. I mean, those are the people who are going to need more. And then develop standards to simplify this information of benefits and coverage like I talked about. So lots of things for private insurance. There are also changes to Medicare. Like I alluded to earlier, I'm not going to get paid for hospital-acquired conditions or readmissions. That's good. Why should I bring you to my hospital and let you get sick, right? I should be punished for letting you get sick. You get a bloodstream infection, you get a pressure ulcer, you get a pneumonia. That's shame on me. That's bad medicine on my part. We should do better than that. And I sure as heck shouldn't be rewarded by being paid for it. That makes no sense at all. This independent payment advisory board was established. This is the so-called death panels, and their purpose was to reduce the spending growth. They had preset limits on how much we expected Medicare spending to rise, and they were, if the Medicare spending arose above a certain point, a trigger would be hit, and they'd have to come up with ways to decrease the spending. Now the problem that troubles me about this, they can't ration care, they can't increase revenues, they can't change benefits, and they can't alter eligibility or cost sharing. So what can they do? Decrease payment to providers. That's all I see up there. So that's not very good for me. The last thing they can do is decrease payment to providers. So it'll be interesting to see what levers they can pull to control the cost. It allows the creation of accountable care organizations, which is a conglomeration of hospitals and physicians who deliver care based on quality outcomes. Value-based purchasing, which is another measure by which we get paid not for how much we do, but we get paid based on our outcomes, whether we provide good heart attack care, whether we provide good pneumonia care, whether we provide good heart failure care. And then primary care physicians, who are the cornerstone of all healthcare delivery. I'm a cardiologist, so a specialist singing the praises of primary care physicians. They're the ones who have been, what's the right word, not taken care of very well over time in the grand scheme of things compared to specialists. They're the ones who deserve some help. And then we're going to get rid of the copays for preventive services. Why would we want a copay on a preventive service if it's going to prevent the people from getting the care? And then the healthcare plans, the additional thing, and this is something we'll talk about a little bit more as we move on. The plans have requirements to expand their coverage to be a compliant healthcare plan. You have to provide ambulatory services, emergency hospitalization, maternity and newborn care, mental health, prescription drugs, rehab. I mean, sort of the things you want covered across the board. Now the problem is if you're a 58-year-old lady, you probably don't need maternity and newborn care. You know, you may not need pediatric services, but again, in order to get coverage, everyone has to pay into the plans that cover everything to make the economics work. Okay, so how do we pay for all this? It's a lot to pay for, and this is the question. I don't know that we're going to be able to pay for it all, but we certainly couldn't pay for what we're doing, and that's where I said, remember where we came from. What we were doing was not sustainable. There's federal money going in for the first 4 years, then it's 90-10 state and federal. Premiums for the citizens, either taxing or paying your insurance in the individual mandate. We've asked employers to share a burden of the cost by forcing them, quotation marks, forcing them to provide insurance. And then there's some taxes on medical devices in the pharmaceutical industry, which, you know, that sounds good to me. All I know is that they got a bigger profit margin than we do. So let's bring the cost down if we can. We don't want to stifle innovation. We don't want to stifle creativity, because that's what, you know, capitalism is all about, is creativity and innovation are why we have new drugs and devices. People aren't going to do it if there's not a profit margin in it. At the same time, we can't have them taking the healthcare dollar out of healthcare while we're all trying to figure out how to keep paying the bills. So other tax changes, they're going to decrease reimbursement for over-the-counter drugs. They're going to change some deductibilities. They're going to tax wages on people earning over $200,000 and $250,000 filing jointly, and then a 3.8% tax on those who are in the really super high bracket. And I think I have a graphic here that shows that. If you look, the blue is the current average federal tax rate based on your income, less than $10,000 all the way up to $200,000 to $250,000, $500,000 to $1 million, and greater than $1 million. And you'll see that the orange only comes in on those individuals or families making above $200,000 a year, and it's a progressive increase up to here. So it's designed to affect those theoretically who should be most capable of paying it. But again, there's not enough rich people on the planet to cover the cost of this, okay? You can tax the rich people all you want, but there's not enough of them to cover the cost of everything. Everyone's got to share a burden in this. We just don't have the money. All right, so that's sort of where we are. Take a pause. We're 35 minutes into the talk. Are there any thoughts or comments or questions before we go into our one-year progress report? Yes?
When we talk about the costs, and I know there's an American attitude that says, why should I pay taxes for somebody else's health care?
Mm-hmm.
So I would ask you to talk a little bit about the public health issue and how much better off we all are to live in a healthy society. Would anybody in here want to be living in South Africa right now?
Yeah, so that's the great, I think, I don't know if you heard her question, but her question was sort of the cornerstone of one of the debates was, why should, some argue, why should I be responsible for someone else's health care? And her counter argument that I heard was, don't we all want a healthier society, and isn't it our responsibility that we have benefits when we have a healthier society? And that's the great debate that goes back and forth. And I think, and that's where I sort of preface my remarks about we all come into this with a different sort of viewpoint. And it's based on what we see every day. I see people who can't afford health care every day and are destitute and bouncing in and out of my emergency department. That's the world I live in. Other people live in another world where they're independent and they've taken care of themselves, they've worked hard, they've done everything they can to provide for themselves and their families, and they don't see why other people aren't responsible for that themselves. And I appreciate those differing viewpoints. I don't pretend to have an answer for you on that one, and that would be that almost sounds like a church talk to me. But that's a separate talk altogether, but it's the crux of the debate about why people argue against or for the individual mandate. Mary Ellen?
When I was a kid, my dad always said, I would rather pay for the insurance than have to use it.
Yeah.
And so he never minded, paying it. And
Yeah.
I think that's kind of a basic attitude,
Yeah.
in my mind anyway.
Yeah. And a question over here?
Yes, you alluded to insurance companies have excessive profit. Do you think this is going to lead to a single-payer system like they have in Europe and in Canada?
Repeat the question.
Yeah, so the question was excessive profits with insurance companies, part of the act being built to sort of minimize their profits. How will this affect insurance companies? We'll talk about that in a second. I have some slides that address that. And will it lead to a single-payer system like in Europe or other places? We're not ready for a single-payer system, and I wouldn't want the federal government to be the single-payer system, at least not the way it's doing it now. There's too many inefficiencies and bureaucracy. So, 30 years from now, we may look at this as one of the first steps towards that, but I don't think I would go so far as to predict that that's a necessary outcome of this, that this step will automatically lead us to that. It could happen, but I don't know. I mean, only if this works would that be the next step. Let's look at the progress report. We got a post set of questions to test, and then we'll have some more conversation because I think some of the questions will be answered here. So, if the act was designed to increase the number of uninsured, has it done so? What do we think? Yes? No? Yes? Yes, of course. Well, maybe not of course, but it certainly has. Yes, over 7 million served, much to the chagrin of the grand old party, because they wanted to say it didn't work, but it at least accomplished one of its main goals in this regard, and so that's good. 7 million were enrolled, and no matter which survey you look at, the numbers of uninsured has declined significantly. Whether it's the RAND Corporation, Gallup, Commonwealth, Urban Institute, CDC, from about 18-20% down to, depending upon where you look, the numbers of the uninsured has declined. And the decline has been largest, of course, in those states that have expanded Medicaid, because that it put a lot more people into the role of insured. Now, you can argue how good or not good Medicaid is, but as an insurance product. But if you have no insurance, Medicaid looks pretty darn good, okay? And if you're a hospital and you have people coming in and they're not paying you anything, well, heck, I'll take Medicaid even though it doesn't cover my cost, because it's better than nothing. So it's important, at least from that perspective, the individual perspective, whether we should be, leading back to the question that was asked up here earlier, responsible as a society for paying for everyone, that's another question altogether. But we did see that it accomplished that initial goal of decreasing the number of uninsured people. Okay, question number 2. Has insurance under the law been affordable? We got at least one testament that it might be more affordable than her prior plan. What do you think? Has it been? So, remember, most of the people, 2 out of 3 who applied got subsidies, so they would say it was probably more affordable. They got subsidies. And if you look at the change in premiums from last year to this year, on average, it's gone up between 3 and 4%. Depending upon where you are, they've gone up in Tennessee, in the Nashville area to, but this is as of early September, about 8.7%, and some of in Colorado and other places, the rates have dropped, and that all had to do with individual unique factors related to the marketplaces there, and whether new companies came into the markets and offered plans, the competitions of plans. Just another way to look at the rate changes to 2015, it decreased. This is what the cost of a silver plan. Remember, the plans were stratified according to bronze, silver, gold, and platinum. And the bronze plan covered 60% of your costs, the silver 70%, gold 80%, platinum 90%. And of course, the more your costs that are covered with the insurance, the higher the cost, the lower the deductible. So this is a silver plan for a 40-year-old was sort of just the reference standard that they used to compare. And it dropped in, many states, went up in others. But on average, what I read over the course of the weekend was that it was about a 5% increase overall. But what was the problem with this? Remember this quote? Yeah, I remember it very well. If you like your plan, you can keep it, period. But the problem was that wasn't true. And that's probably the single biggest thing that I've heard repeatedly about the problem with the Affordable Care Act, is that it required many hardworking Americans who had narrow plans. Remember, the plans now have to offer maternity health and pediatric care and prescription coverage. They have to be compliant. Some of these plans were grandfathered in, so they could have been kept by the insurance companies, but they chose not to keep them, so they dropped them, and the people who had those plans then had to get new plans. And so then they said, Obama lied. And people knew that this was going to happen, and yet he said it repeatedly and repeatedly and repeatedly. You can keep your doctor, you can keep your plan. You can keep your doctor, your plan. If you like your plan, stay with it. The internet's full of YouTube videos on this. I was going to put one on here, a montage of you can keep it, you can keep it, you can keep it, you can keep it, but you can't all the time. So that's the problem, and that's probably the ugly. I would say that's the ugly in the talk. Yeah.
So you're saying that it's the company, the healthcare insurance companies who are making it so you can't keep your plan?
So, no. Yes and no. So the plans that were dropped, either the health insurance companies chose no longer to offer them for whatever reason. Much of it was because they were no longer compliant. As an example, my brother had a plan that didn't offer maternity care. It was no longer compliant. The company said, we don't want to offer it. And so then he got dropped. He had to get a new plan. Because the act said that, yeah, you can keep your plan if it's compliant. They were grandfathered in. Pre-existing plans were grandfathered in, but not all insurance companies chose to continue those plans. So it's a combination of factors. That was a big problem.
You have a question over here.
Yeah.
I hear conflicting things, whether abortion is covered or not covered in these plans, and this is causing huge problems with religious organizations?
Not covered.
Not covered.
Nope. On the plans in general.
Repeat question.
It had to do with whether abortion services were covered according to the plan, and that never would have been politically feasible to mandate that that would be covered. So you can imagine why that wasn't.
Yeah.
Okay, so we've expanded care. They may be affordable or not, depending on where you live, if you got to keep your plan. So if you didn't get to keep your plan, it clearly wasn't affordable. What about healthcare outcomes? It's supposed to improve outcomes. Remember, we talked about all that litany of things that how we're going to change the delivery of care. Do we think it's actually made it better or not better? I think the answer on this one is probably we don't know. It's just too darn early to sort it out. We do know this, that if you look at 60% of the people who got new coverage, who didn't have coverage before, 60% of them went to a doctor or another provider, went to a hospital or had a paid prescription. 6 of those 10 who did that wouldn't have been able to get help before. So I would say they at least had better outcomes, right? At least they're not providing services for people who didn't use them or didn't need them. And so that would at least partially translate into an improved outcome, but it's not, you know, it's way too early to say our hospitalization rates are declined, our readmission rates are declined, anything, you know, really substantive and meaningful at this point in time. Another measure about whether healthcare outcomes are improved, how long did you have to wait to get your first doctor appointment to see your primary care? And these were new Medicaid enrollees through the exchange. 41% was a week, 26, 8 to 14 days, you know. So those who are enrolled are getting reasonable access. I don't know, it's not great. I think if you have to wait more than a week to see your doctor and you're sick, that's a problem. But certainly, I don't think anyone would be surprised if that happens. We certainly have a long way to go in that respect. Okay, question 4. Will the online exchanges work better this year than last year? I mean, seriously, could they be any worse, right? You know, I don't know how it could be any worse. They did have a couple improvements. One, and this was stunning to me, the application process last year had 76 screens to go through. Okay, 76. I mean, I can't imagine that. Down to 16. Navigation certainly has improved. I went and it was clicking. It was humming yesterday on a Sunday. It's early and I don't know how much traffic was on it, but certainly they've got better bandwidth and it's easier to use. There's not a problem. They have a feature now where you don't have to log in and create a name and all this stuff. You can actually shop, like window shop without registering, which is nice. So that's improved. And compared to 2013, the one thing that I read early this morning, they had some issues over the weekend with logins and passwords. That passwords were getting frozen and people had to spend some considerable time calling some site to try to get logins or passwords reset. But certainly nothing like the debacle of last year. Okay, has the healthcare industry, so this is back to the insurance company question. Has the healthcare industry been helped or hurt by the law? And by that I mean insurance companies and hospitals. We'll look at them separately. Okay, so Wall Street analysts say new customers to insurers. We're driving people towards the insurers. They're going to do better. And new paying patients to the hospitals, except where? In Wisconsin and North Carolina and other states where they didn't expand Medicaid. And remember, one of the purposes of expanding, 2 things happened. One, they expanded Medicaid. At the same time, they cut Medicare payments to hospitals. And they cut the Medicare payments to hospitals because they knew there were going to be more insured patients with Medicaid. So if you were a hospital, I'm a hospital, in a state without Medicaid expansion, all I saw was the cut. Okay? That doesn't feel very good. We had a $50 million. $50 million. Now we're a $1.4 billion health system. We had a $50 million decline in revenue from last year to this year because of this. Okay? And it was supposed to be offset by Medicaid expansion. We let go 130 people. First layoffs we've had. Other health systems are laying off thousands of people. 900 to 1,000 rescaling and how they do things. So this is a big deal, and that expected link between Medicare decline in reimbursement and increase in Medicaid patients that didn't happen has been a problem. The insurance industry has seen benefits because there's been a growth in demand for private insurance across the board. And I think just by the fact that more people are offering plans on the exchange, I mean, the insurance companies are for profit. So more of them getting interested in being on the exchange says that they must be doing better. And if you look at their returns, the S&P 500 healthcare index has outperformed the S&P 500 in general since last year. And most healthcare companies have posted healthy profits so far this year. If you look at for-profit hospitals and look at their book of business in states where there's Medicaid expansion versus no Medicaid expansion, there's a company called LifePoint. Profits up in Medicaid expansion states, profits neutral or down a little bit, and no Medicaid expansion states. So even the hospitals have done better. But there's been $260 billion cuts to Medicare. Again, it was supposed to be offset by Medicaid expansion, as I already cried about. Try not to cry too much. We didn't expand. Yeah.
But aren't hospitals actually that are not covered by that particular situation, aren't they taking a different position in terms of their doctor staff? Their doctor staff in terms of they now want more billable hours. I know a doctor that's retiring for that very reason now locally, because he doesn't want to be under the gun to have the time that he wants to spend with the patient.
So the question was, because of Medicaid, failure to expand Medicaid, aren't the people who run the hospitals going to their providers and say, all right, run on that treadmill faster, crank out those widgets, do your work faster? I would say, yes, we're being asked to provide more. We're asking our providers to be more productive. Not just because of that, but for a variety of reasons in general. And we're also creating increased demands on them every day that get in the way of them being more productive. Rules and regulations about what they have to document, how they have to document it. For some of the old dinosaurs, you know, putting an electronic medical record in the room, so they have to learn how to work with a computer and a patient at the same time, which is very challenging if it's not something that you're used to doing. So there's other things that have gotten in the way, but that definitely is one of them.
I resent being called a dinosaur. The proverb is, if the shoe fits, wear it, right? Reminds me of a joke, too. Okay, so how is the expansion of Medicaid fared? I think we talked about some of this already. Remember, we talked about it was optional for the states. Only 27 states have expanded. There's a gap for those who earn too much for Medicaid, but too little for a subsidy. And then many states are reconsidering their Medicaid failure to expand Medicaid. If you look at the enrollment, and we showed this slide or some of this data earlier, you know, in the states where they expanded Medicaid, there's been a 5% increase in number of insured. Here's Wisconsin, a little bit of increase in Medicaid enrollees. They call it the woodwork effect. Just talking about Medicaid, people crawl out of the woodwork and, you know, and start, you know, getting enrolled. So it's definitely going up. Interesting, and I'll show you some. For some states, they thought that overall this expansion would result in a net savings, no cost at all. That there would be huge potential economic effects. I mean, it brings more jobs to your community when you have more insured patients, more healthcare dollars in the community, more people in the state. We estimated in the state of North Carolina that all told we lost $51 billion by not expanding Medicaid, and I'll show you that in a second. There's increased revenues to hospitals, but what happens beyond 2017 when that federal funding declines? Who's going to pick up that gap? That's what has the state governors and state legislatures so worried. Overall, if you fail to expand Medicaid, there's $423.6 billion in federal funding between this 10-year gap. Local hospitals give up $168 billion of that dollars. And this is the interesting statistic. For every dollar a state spends expanding Medicaid, it's been estimated that you'll get $13.4 in federal funding flowing into the state. So not doing that is sending a lot of your own tax dollars to other states, at least in the short run, and that's, you know, something I think we have to be cognizant of. If you look at Wisconsin is down here. This is the lost billions. This is an estimate by the, I can't remember who did, the Urban Institute, Robert Wood Johnson did this analysis. They estimated they would lose an average of 12.3 billion in funding, and hospitals 3.7 billion. It's a lot of money, you know, for your state that you're not getting, over the thought that you might have to be on the hook for more costs later on. And my argument is take the money while it's available and bail out later if you don't like it. It's hard to bail out once you've been giving people an entitlement or a benefit, but it's probably what I would do. And have we contributed to a slowdown in healthcare? Healthcare spending, again, I think it's too early to know. We actually think that it was slowing down even before the Affordable Care Act had come into place. We hope that the rate of growth continues to decline. Some of this is due to reductions in wasteful or unneeded care. It's possible that there'll be an increase in costs because we're getting more people in the healthcare system. It's not known. If you look at this trend, this is from 1961 up to 2014, and this is the rate of increase, annual rate of increase in growth. And you can see that the annual rate of increases has been declining recently, but it's still more than we can afford, and we've got to continue to keep it down. So I think the jury's out on question number 7. And then just 2 more quick things before we finish up and ask for some questions here, and I apologize for going so long. What's the future for the ACA? What's going to happen? Because we know something happened in the beginning of November. We saw that the GOP had a net gain of 7 seats in the U.S. Senate, right? 7 seats, and now they have a majority, 52 to 44. We saw that the GOP had a net gain of 12 seats in the U.S. House. Look how red that map is now. And they're 244 to 184. They haven't had this much of a majority since I think it was 1929 or something. It's a historical change in the landscape of the House. And so the thought is, well, what's the GOP going to do? They're going to repeal Obamacare? Sure, they're going to. You know there'll be a vote to repeal it. But the problem is, I'm not a constitutional scholar, but they don't have enough to override a veto. Remember, it takes 2/3 of the Senate to override a veto, and they don't have a 2/3 majority. They have a simple majority of 52, not 67. So it would be vetoed, and they wouldn't be able to override it. But they do have things that they can do, and that may get bipartisan support at doing, and that's getting rid of this 2.3% tax on medical devices. No one really liked that. Even some of the Democrats didn't like that. They may go after the employer mandate in some way, shape, or form, alter that. They may go after this definition of full-time work. Remember, they decreased the definition of full-time work from 40 to 30 hours so that more people would have to be covered. Again, the strategy, it's not a tax. We're just making it a tax by changing the definition. And so they changed that. They're talking about going after the Independent Payment and Advisory Board. And then there's a suggestion that they may advocate for a copper plan, which is a cheaper plan with higher premiums and lower deductibles. The problem with these, and this is just sort of an off the tangential comment, the problem with the health insurance these days, to make it affordable, the premiums are lower, but the deductibles are so much higher. And you know, a $2,000 deductible or a $2,500 deductible is standard. Many of these high deductible plans are $5,000 or even more for family. And I heard a statistic when I was in Washington, D.C. at a talk that said that, and this was stunning to me, that 40% of the American public cannot afford a $2,000 deductible for a medical payment without selling a major asset, like a TV or a car or something that's in their house. So that's how terrible we are at saving. So if you don't have $2,000 to cover that, then all that means is these plans with higher deductibles, people are going to not pay their bills when it comes to the hospital, and then put my hospital hat on, I'm just going to see more bad debt, and I'm just going to have less collected revenue, and I'm going to be in deeper trouble financially trying to care for the poor. So it's going to pose some problems. And then, of course, the other plans, so the GOP may be attacking the Affordable Care Act, and the other place where the GOP hopes the Affordable Care Act will get some attack is the Supreme Court challenge, and the justices agreed. 4 justices on the court have to agree of the 9 to hear a case, and 4, we don't know which 4, agreed to hear this. And this is
there's a clause in the act that says that subsidies will be available to anyone who gets their health insurance through a state-run exchange, an exchange established by the state. And so the strategy on the part of trying to bring down the Affordable Care Act is to say that this meant a state exchange. Now remember, many of the states didn't set up their own exchanges, they defaulted to the federal government. And so they're saying if you're using a federal government exchange instead of a state-run exchange, then you shouldn't be allowed to get a subsidy. And the question is, was that a drafting error, a typo, or was this intentional language? There's been intense debate about whether they really intended it to be that way or whether it was just coincidental. And if they do take it away, it could affect up to 4 million people. So that won't be heard. There'll be preliminary discussions on that in March, and then they'll be heard by the court in June. So it'll be long after people have gone through the enrollment period before we hear the outcome of that one. And it's going to be interesting to see where that ends up. All right. Questions? Got one in the back first, and then we'll get to you. Good.
Yeah, the question I have for those who want to repeal the Affordable Care Act,
Yeah.
what do they want to replace it with?
Well, and that's exactly one of the reasons they think it won't be particularly palatable, because from a political strategy, to repeal something is one thing, but to leave the country, first of all, it'll be very expensive to repeal it. That'll be a black mark on the GOP. Number two is they don't have a viable option, and the American public, as stupid as Mr. Gruber thinks we are, is going to figure out that that's not where the GOP wants to be either. So that's a very good point. You had a question?
When we don't have insurance or the Affordable Care Act, if we didn't have the Affordable Care Act, who pays for poor people when they go to the emergency room? Who pays that bill?
So that's a really good question. And so when you show up in an emergency room, there's a law called EMTALA, the Emergency Medical and Treatment and Labor Act, that requires that anyone who shows up to the emergency department get treatment, that they get stabilized. If they're in labor or if they have an emergency medical condition, that they be given treatment to stabilize their condition. If it's an elective problem and there's not an urgency, once they're stabilized, they can be sent for outpatient care. But if you have a life-threatening condition or issue, I can't even ask what your insurance status is before I treat you. That would be, like, it's against the law for me to ask that. So you have to be treated up front. Doesn't matter whether what color your skin is, what color your passport is, whether you have a passport, whether you're illegal, whatever. Anybody, illegal, non-illegal, has to be taken care of, which is a good thing, because it was to prevent people from shunting all their no-pay patients to other hospitals, okay? Now you come in, you get a big bill, who does pay for that? And that's, in the long run, we all pay for it, because the costs get shifted to those with insurance plans. In our hospital, 25% of our patients have private insurance and 70 to 75% have Medicare, Medicaid, or no pay. And so we have to make all that money to pay for everyone else on that 25% of the private people. But you'll get a bill. You'll get a bill, and depending upon the hospital's program, whether they have a charity program that offsets your costs based on your income and other issues, you'll get a bill. And some hospitals, depending on the aggressiveness with which they pursue their collections, will turn you into a collection agency and will go after your assets and whatnot. It's highly variable from health system to health system.
Another question over here?
Yeah.
Bill, it's a little bit, maybe even outside the scope of your talk, but would you comment on fee for volume versus fee for value, and that kind of change in paradigm, which I think most people believe has to happen?
Yeah.
ACA didn't do much about that, but just any thoughts on that?
Yeah, so what Dr. Scanlon is referring to is we're undergoing a major paradigm shift in how we get paid. And this shift has been gradual, more gradual than people think over time. So back in the mid-1960s, when Medicare came into place, everyone thought Medicare was the end of health care and this was the worst thing that could ever happen. Who wants me to take away their Medicare now, right? Don't take away my Medicare. What happened in the early days of Medicare is anytime some of the dinosaurs in the room ordered a lab test or a office visit, they got paid for it. Didn't matter what it was. I ordered a CBC, I get paid for it. I ordered an office test, I get paid for it. I get it, whether it was necessary or not, okay? Fee for service. What I do for you, I get paid for. And back then we had reasonable money. People were ordering reasonable tests. It wasn't a big deal. The demand and the supply were fine. Well, over time, that strategy led to people ordering a whole bunch of tests that weren't necessarily necessary, seeing patients for conditions that may or may not be needed to be seen, ordering expensive tests. And we evolved to a system where we're now more highly rewarded for ordering tests and doing procedures on patients. The best reimbursement is on surgeries and high diagnostic testing than it is for seeing patients in the office. And this is the problem with fee-for-service medicine, is that I'm not incented to sit down in the office and have a long conversation with you about what your wishes are and what your desires are for your health care and how you want to live the last few years of your life and what's important to you. You come in with chest pain, I don't talk to you about it. I say, okay, get a stress test. Why do I get the stress test? Because one, it's easy for me to order. I don't have to spend too much time talking to you. I get paid for it. And so we recognize that's wasteful in healthcare. That's not the way to do it. And the Affordable Care Act addresses that. Doesn't want us doing that. Don't reward me for ordering something. Reward me for making you better. Don't look at what you did to me. Look at how I responded to what you did to me, okay? The value, not the volume. So if you can make me really good without ordering a bunch of tests, that's just as better, maybe even better than ordering a bunch of tests and not knowing what my outcome is. So we're shifting. We're getting paid now, instead of for ordering a bunch of tests, we're going to be paid for looking at what our outcomes are in healthcare. What's the rate of your diabetic patients who have a hemoglobin A1C less than 7%? How many of your mothers got prenatal care? What percentage of your patients had C-sections versus didn't? How many patients got all the things we know are necessary when they have a heart attack? When you have a heart attack, you should get aspirin. You should get a beta blocker. You should get a statin. You should get to the cath lab within 90 minutes. All these things. And if you meet all those, then we get paid for that. If you don't meet them, you get a penalty. So we're changing from fee-for-service to outcomes. And the problem is the transition is best described as scary as hell for us. Because all I know right now is that my income and my patients depends on me generating those visits. And in the future, it won't depend on that. But in the transition, it's a mix. And I don't know which patient I'm getting paid for on fee-for-service versus which patient I'm getting paid for on value. And this, we describe it sort of like a bridge across, a shaky bridge across a roaring river. And I know that where I've been is not feeling too good. Where I'm going, I think, looks pretty good. And that bridge just doesn't look very fun to get across, but I know I got to get across it. And that's where we are right now. Yeah?
Let me have a follow-up question. Of your $1.4 billion for a mission health system, how much of that is fee for volume and how much of that is fee for value? Any rough estimate?
I haven't thought of it that way. Well, let's say, 70 to 75% of our payer mix is Medicare, Medicaid, and we can face up to a 2% penalty if we don't. So 2% is 75% of that. So tens of millions of dollars, lots of money.
But if you take your $1.4 billion, then you've got $1.3 billion coming in fee for volume.
Yeah, right. And still fee for volume. That's, they talk about it being fee for value, but we're still very heavily dependent on fee for service, correct? Yeah.
Thank you.
You're talking,
One over here first and then,
Don't you think that while they're addressing this issue, they should also address the issue of the liabilities that hospitals and doctors are facing and limiting the amount of liability dollars?
I did not plant him in the audience, okay?
That would have a dramatic effect.
Yeah, well, it's really interesting. There have been lots of studies. So the question was, how much, I'm paraphrasing, rephrasing your question, how much negative impact on healthcare spending does defensive medicine have? I'm ordering a test because I'm afraid if I don't order the test or do something, you're going to be sued. And doctors love to talk about how bad this is and how much this can be harmful to the cost of medicine. It's better than it used to be because there have been some significant changes across the board. But there's no doubt, especially in emergency department medicine, that there's a lot of waste that's driven by this sense of, I don't think it's a stroke, but I better order the head CT anyway. I don't think it's a heart attack, but we better watch him overnight because if I send him home and he has a heart attack and I get sued, it'll be a problem. I don't think it's a, so they order test. And that's the sort of, I assume we all know what CYA stands for, CYA medicine, which is, probably not what we need.
Over here. Excuse me, over here.
Yes.
You talked about when you're talking about the plans being canceled.
Yes.
Now, and you say because they didn't comply, there was going to be financial cost either for the provider or the insured if they kept those plans. Is that correct?
Correct. Right. Well, not for the provider, but for the insurer.
Yeah.
Yeah.
So the government actually made it an incentive to drop those plans.
Yeah, I think that, yeah, exactly, right. Now I see your point, exactly. They made it, there would be a tax on these plans over time, and that was one of the other things that Mr. Gruber had alluded to, that eventually all these plans, these Cadillac plans would get some kind of a tax anyway, and that was what they were referring to.
And isn't there an ethical issue to me with providing health care and having for-profit? Insurance companies aren't they have all the control. They can tell you, I know that people who are afraid of Obamacare were saying, well, I don't want anybody telling me what he can and can't do. Well, it's even worse than the doctor or the government telling you what you can and can't do by having the insurance company tell you, because they're all wrapped up in having, making profits.
I'm not, I didn't come here to be on a soapbox, but it's hard to not hit that softball, right? I would agree, we're a not-for-profit health system, which doesn't mean we don't try to make money. We try to make money so we can reinvest it into the health of our community. And that's what so not-for-profit doesn't mean we don't want profit. It means all the profits go back into the delivery of health care and making our health care community better. A for-profit health system, so if you have HCA, or in our community we have a for-profit system that's just moved in called LifePoint, and LifePoint I think has a hospital in Marquette, Michigan. And I'm embarrassed to say they're affiliated with Duke University, which is where I got my degrees. They have a responsibility to their shareholders, a fiduciary responsibility to take profit out of the system and have dividends and profit for their shareholders. Okay, that's what a for-profit company does. And so it's just a fundamentally different approach to what you expect out of your health care. And they may not offer Mission Health. We serve the people of Western North Carolina to improve the health of people in Western North Carolina. LifePoint, at least as their mission is to, or any other, I don't mean to pick on LifePoint, but a for-profit company has a fiduciary responsibility to make money for their shareholders. And as a result, they may not choose to offer services that we have to offer. We have to offer psychiatric services. We have to offer pediatric services when they lose money. We have to offer the things that other people don't want to offer, and they won't do it, and then those patients will just come to us.
I'm sorry, but we do need to cut off the questions. We got to vacate the room by 8 p.m. So if anybody here is able-bodied and would love to help stack chairs, we'd love to have your help. And let's please give Dr. Hathaway.